Hey, this is Jeremy with Faithful Guardian, and today we're going to be talking about documentation. Documentation is going to be probably one of the most important things you do as part of your job. It's going to help, with quality assurance, research, and at the same time, it's also going to make sure that the department that you work for, they're actually getting paid for the things that you do on the truck. So there's a couple different types of verbiage that you may see. You may see PCR or you may see EHR. So PCR stands for Patient Care Report, and EHR stands for Electronic Healthcare Record, and both of them are essentially the same thing. And what they do is it's just the documentation for the call that you did. This includes the vital signs, this includes what you saw, what anybody was said on scene. These are all the things that help guide you to your treatment decisions, and they kind of track your record from the moment that you arrived on scene, or the things that happened before you arrived on scene, what you saw whenever you got on scene, what you did, and what happened all the way to the hospital and up to changeover of care at the hospital. And this is your way of documenting that, and kind of defending your actions, or just explaining yourself in general. So there's two types of information that you really need to be familiar with. And so you have subjective information and objective information. Now, the way that I was able to remember the difference between the two is subjective was spoken to. So subjective starts with an S, so does spoken. And so these are things that we're not able to see. These are things that people tell us that we can't necessarily tell. We can't tell what happened before we got there. We can't tell what our patient's actually feeling. We can tell that they may be feeling something, but these are things that you're not able to see yourself, such as pain level, nausea. Where specifically the pain hurts, the type of pain. All that is subjective information because it is spoken to you. Now, objective information. Objective information is that's the information that we actually observe. So, if the vital signs, that's an objective piece of objective information. Blood loss, that's objective information. Do we see any bruising? So, battle signs, raccoon eyes. Cullen sign, those types of things, those are all going to be objective information. So include that blood loss, the bruising, the vital signs, all that is going to be objective information. Now there's many different ways to include this information into a PCR. You can do a chronological narrative where you mix everything together. You can do an SOT, which is subjective objective treatment. You're breaking your PCR up that way. There's multiple different PCR types or formats that you can actually use, and there's not one that's necessarily better than the other. There's the ones that your employer is probably going to mandate that you use, or if they do give you a little bit of liberty, you find your own writing style, and that's going to be kind of the best way for you to be able to document and kind of paint your story. Now, the PCR's got a couple different purposes. It's number one, it's for the continuity of care of your patient, and so it's also going to be for EMS research and billing, and it's also going to be for your incident review and your quality assurance. So, for example, the physicians at the hospital, they have the ability to actually get onto a system and look at the PCR that you wrote as soon as you hit submit. And this is going to allow them to be able to make better decisions because, especially if your patient's not necessarily going to be in the emergency department for a long period of time, their shift change. Somebody who didn't get their report from you for, an adequate picture to be painted for them. So any physician, they're going to be able to have access to those PCRs. And that's going to be able to kind of help, guide them in the right direction. Because there's information that we can see working in the field that the physicians, they're not going to have access to. Neither are the nurses. So there's also the minimum requirements for billing. So that's the minimum assessment standards, and they come with a minimum data set. And that minimum data set, that's actually coming from Medicare and Medicaid here in the continental U.S. and by NHTSA, which is that National Highway Traffic and Safety Administration. And so they kind of set that minimum number of information that is that's supposed to be obtained, And they do that for research to figure out, are the trauma centers being utilized? Are we seeing an upspike in specific types of injuries? What are we doing for these types of injuries? Are we flying these patients? Are we not? And it's going to kind of help guide, the development of EMS in the hospitals and things that are in your state and in your region. Now, again, that's with that EMS research. They obtain that from that minimum data set. Now, there's also incident review and quality assurance. So, for example, if you give a medication and you document that their blood pressure is low. So, if you give fentanyl or morphine or any other kind of analgesic drug that can have hypotensive properties, if you give those to somebody who's already hypotensive, that's a contraindication. So that may raise a flag up on your quality assurance side, and they're going to be like, well, why did you do this? And it can involve remediating training and things like that. And it's not a way to get you in trouble. It's a way to make sure that everybody's kind of following a consistent standard and providing the current standard of care that is expected to be provided by your department and by your medical director. Because again, whenever we operate, we are an extension of our medical director, and we're acting for them out in the field. So you kind of gotta keep that in mind. Now, there are some special circumstances, such as like mass casualty incidents and refusals of care, that may require just a little bit more care to the documentation, though all documentation needs to be, really, really well. So, refusals of care is one of the most commonly litigated forms of, care or contacts that we come in contact with. So, because if you leave somebody on the side of the road or at their house and they get extremely sick or they potentially die later, the family can always come back and say, well, hey, EMS came out, why didn't they take them? And so your refusal of care, it has to include, certain pieces of information. So it must be refusal of care must be a decision made by the patient or their caregiver, somebody who's, of sound mind and body. And, they have to be able to understand the situation. They have to be able to understand the risk of refusal of care up to and including their own potential death. And, that's something that, you need to document. Document what the patient states their reason is that they don't want to go to the hospital. And that's going to be a way for you to be able to defend yourself. And, if, these cases may not come up until 5-7 years down the road. And if you don't paint an adequate picture, are you really going to be remembering what happened at that time? And if, push comes to shove and, you're trying to get somebody to go, and those refusal, they're adamant about not going, you can always call your medical control and have and speak to your medical director, or have your patient kind of speak to medical control. That way, medical control can kind of get a better understanding, and they can help you make your decisions. And if they don't feel, medical control feels that they need to go, well, there's options there. And but at the end of the day, this documentation is a way to cover yourself and provide that continuity of care for your patients. And those are the really big takeaways that we need to get from this.